So in the next 15 minutes or so, I'm going to be talking about post-operative Crohn's disease. And this is the outline of my talk. I'm going to be talking about the magnitude of the problem, not only the magnitude of Crohn's disease, but also the post-operative recurrence, the putative causative factors for recurrence. How do you diagnose recurrence? What are the risk factors for recurrence? And the management of recurrence. So this slide shows you the worldwide occurrence of Crohn's disease. And the reason why I put it there is to show you that there's no Africa on the world map of IBD. So as we can see that the lowest prevalence of IBD and Crohn's disease is in Asia. The highest seems to be in Australia, North America, and Europe are next. And the same is true for incidence. So I hope these kind of meetings will spur the interest, and in the future, we will have Africa on the worldwide map of Crohn's disease. And as a preamble, I want to start by saying that surgery is not curative in Crohn's disease, and post-operative recurrence is the norm. So my talk is more of question and answer sessions. So we're going to be discussing what percentage of patients with Crohn's disease need surgery, what percentage of patients of Crohn's need a second surgery, what is the site of the recurrence, and lastly, I want to emphasize that the endoscopic recurrence should be considered as a prodrome for clinical recurrence. And I'll be talking about this in my subsequent slides. So the first question first. What is the need for surgery in patients with Crohn's disease? So if you set the mark at 10 years, then within 10 years, approximately half the patients would require surgery. And if you follow up for a little more, then the figures would rise. What about the second surgery? And the answer to that is also very simple. This is the 5-year risk of surgery of a second surgery is roughly 1/4, or 25% of the patients would need at least 2 surgeries in their lifetime. And these data that I just presented to you in the previous 2 slides, they come mainly from studies performed in Europe. This is from Sweden, Norway, Wales, and France in the last, this is between 2000 and 2011. And you can see the figure ranges between 25% and 60% of need for surgery within 5 years of diagnosis. So what are the 3 commonest surgeries? The right hemicolectomy, that is the ileocecal resection with an iliotransverse anastomosis, a left hemicolectomy, and in some cases, a stricturoplasty. These are the 3 commonest surgeries. Putative factors, why does recurrence occurs? And the most important cause seems to be the role of the fecal stream. And this was a study that was published almost 30 years. The numbers are small, but look at the impact. So they had patients who underwent right hemicolectomy, and this is an ileocolonic anastomosis with a temporary diverting ileostomy. There are only 5 patients, but no recurrence. But in those patients who didn't have a diverting ileostomy, the recurrence was 70% at 6 months. And this is one of my patients. You can see this young lady had multiple perianal fistulae, all discharging an actively inflamed rectum. So we decided to do first a fecal diversion in terms of a diversion ileostomy. And you can see 4 weeks, most of the fistulae are now healed. So that's how quickly it acts. Going on to the natural history of post-operative Crohn's disease, there are 4 phases that we can see. There is the histological phase. This is clearly not symptomatic, but it would set in almost within the first months. Endoscopic recurrence would occur in 1 year, about 80 to 90% of the patients. And this would be followed by a clinical recurrence over a period of 3 to 5 years in 1/3 or 2/3 of the patients. And as I mentioned earlier, the need for surgery at 10 years is almost about 50%. So far I've told you that most of these patients would require at least 1 surgery in 10 years. And this is again to emphasize that endoscopic recurrence at 1 year would be very high. It can range anywhere between 35% to 85% unless prophylaxis is used, versus a clinical recurrence in just about 20% of the patients. So what are the risk factors for recurrence? And they could be patient related. So a young patient who is a smoker is a high risk. They could be related to the disease. That would mean if a patient has fistulizing disease, if he has perianal disease, then he's more likely to have recurrence. Surgery related, patient has had a prior surgery, or if he's had iliotransverse anastomosis, then he's much more likely to have a recurrence versus somebody who undergoes just a stricturoplasty. And this is just to show you the impact of the risk factors. In the center, you can see the odds ratio, and the highest odd ratio of 2 is with smoking. And for penetrating disease, for previous resection and mind-trick plexitis, it ranges between 1.5 or just about 2. And the grade of evidence is mentioned here. The top 3 are all high evidence, high grade of evidence in the form of B. So the next issue that I wanted to take up, which is well known, is what is the site of recurrence? So this nice diagram drawn by one of my residents, this is the right hemicolectomy specimen, and this is the side-to-side iliotransverse anastomosis. So the most vulnerable sites for the recurrence of Crohn's disease is going to be in the neo-terminal ileum, where I've drawn it with a red line, and at the anastomotic side. And this fact was appreciated many, many years ago by Professor Rutgers, and he devised his score, which is still being used, the Rutgers score for post-operative recurrence, or POR as I put it. And that is very simple. I0 means no ulcers, I1 means less than 5 ulcers, and I2 means more than 5 ulcers, but all of them at the anastomotic site. And the neo-terminal ileum is spared. I3 means that it is the involvement of the ileum, diffuse involvement, and the involvement of the neo-terminal ileum. And I4 is the presence of large ulcers, nodules, or strictures, mostly in the neo-terminal ileum. So what does the Rutgers score signify? So if you have in the post-operative phase a score of I0 or I1, that means the chance of a clinical recurrence, not endoscopic, clinical recurrence at 5 to 10 years is 10%. But if this is I3 or I4, then it can be as high as 90%. And this is just to show you that one of my patients who's undergone a side-to-side iliotransverse anastomosis, in the lower part of the figure, you can see this is the ileum. You can identify the villi of the ileum, and that's the colon. So this is a healthy margin. You can see the sutures are still very much there, a few occasional ulcers. So this would be an I1 lesion because the lesions are less than 5 in number. The next thing I'm taking up is the timing of the post-operative endoscopic monitoring, or POEM, and this has nothing to do with achalasia. It stands for post-operative endoscopic monitoring. And for those who are not on any prophylaxis, the POEM is to be performed anytime between 6 to 12 months. And this is, I think, a bit of a controversial issue, and I hope we can discuss this in the question-answer sessions. And the rationale seems to be that endoscopic recurrence at 1 year is to the tune of 80 to 90%. And the grade of recommendation is fairly high. And now the trend is to risk categorize the patients, to divide the patients into 2 broad categories of low risk versus higher risk. And the low risk patients would be older patient more than 50 years. He's a non-smoker, first surgery, the disease duration more than 10 years. And in these group of patients, the illustrative risk at about 18 months is 20%. On the other hand, the high-risk patient, the young patient, less than 30 years smoker, has had surgeries in the past, it can be as high as 50% at 18 months. So therefore, what are the preventive strategies that we have for recurrence? Theoretically, three possibilities. Either we give prophylactic therapy for all, universal. The other extreme is none. We don't give anybody, and if they become symptomatic or if we scope them, then we give them. And the third is to stratify the patients on the basis of risk factors, which I'll discuss in my algorithm. And now for the options of pharmacoprophylaxis. These are mainly from the guidelines from AG and ECHO, and I will just summarize quickly to say that 5-ASA, budesonide, and probiotics have no role. The only three group of drugs which have a role is antibiotics, namely metronidazole, thiopurines, and anti-TNF. So I'll try and take them one by one. I can't go into details for paucity of time, but I'm also going to be using this network meta-analysis. And for those not familiar, a very simple outline is if you have 4 options of drugs, A, B, C, and D, and you have a randomized control trial between A and D, and there is a randomized control trial between D and B, then you can kind of predict that if a future study was done, what would be the outcome when you wanted to compare A with B or B with C. So that's the understanding the network meta-analysis, very simple. And this is, I had to use that diagram to show you this complicated spaceship-like network analysis, which was used, published in 2015. So we have 7 options, you can see, that's the placebo. So the biggest, thickest line tells you the maximum number of studies. Unfortunately, this is 5-ASA versus placebo, and we know that 5-ASA is quite useless. We have data for anti-TNF versus immunomodulators. We have immunomodulators versus placebo, and so on. So I'm going to be discussing first the thiopurines. Busy slide, but 2 aspects: clinical recurrence at 12 months and endoscopic recurrence at 12 months, based on 2 randomized controlled trials. And you can see the forest plot is just the diamond is to the left of the midlines. So thiopurines prevent clinical recurrence at 12 months, and also they prevent severe endoscopic recurrence. Going on to the PREVENT study, we'll be discussing 2 studies on anti-TNF. This was done by Riguero. In 2009, he did a small study of 22 patients, and that was a big success because he showed a terrific response with infliximab. So this was a much larger study of what he had done earlier, and this was 104 sites, nearly 300 patients. The primary endpoint was a clinical recurrence at week 76 and 104, and you can see that the primary endpoint was not met by infliximab, although there was a trend. The orange column that you can see is Remicade or infliximab. The gray column is the placebo. So 12% versus 20% was the primary endpoint at 76 weeks and at 104 weeks. Although there was a trend of a lesser recurrence, almost 18% versus 25%, but this did not reach statistical significance. However, when we looked at the endoscopic recurrence at week 76, you can see over here, 50% of the placebo had a recurrence versus just about 22%, and the p-value was very highly significant. So we can just summarize and say that infliximab is clearly efficacious in inducing and preventing an endoscopic recurrence at week 76 or 18 months. And then a subsequent study, more or less coming at the same time within a span of 1 year, the POSA trial. And here they randomized into 2 groups. One had no endoscopy versus the endoscopic intervention, which was at 6 months, they underwent a colonoscopy. And they divided the patients into low risk versus high risk. The high risk was any of the 3: smoking, fistulizing disease, and a previous surgery. So in the no endoscopy group, as well as in the other group, all patients got metronidazole for 3 months. But in the other group, which is the intervention group, it was divided into low and high. The low risk got no further treatment. The high risk got thiopurines. And if the patient was not or was intolerant to thiopurines, then they added adalimumab. These patients were followed up for a period of 18 months. And then we looked at the primary endoscopic recurrence. last two slides. So this clearly shows that in the active care, it was 49% had recurrence versus 60%, therefore a gain of 18%. So the AGA guidelines recommend that in high risk group, we give anti-TNF. For low risk, metronidazole may be sufficient. And they also suggested, although no study has been done, that we can use the SONIC study model and combine anti-TNF with thiopurines. So this is my last but one slide. This is the management algorithm given by the ECHO. After the surgery, insist on stopping smoking, divide the patients into high risk versus low risk. In the patients who are high risk, we can use either anti-TNF or thiopurines or combine the two, and then follow them after 6 months. And thereafter, on those patients who are only on thiopurines, if they have a recurrence, if they are worsening, they're having I2 to I4, we step it up. In the low risk, we just follow up for 6 to 12 months. And if they have a worsening in the form of a Rutgers score going up beyond I2, then treat as high risk. So I'm going to end now by giving you a few food for thought on unanswered questions. If we know that histological recurrence occurs in the first 3-4 weeks, why should we wait with colonoscopy for 6 to 12 months? And if there's no recurrence at 6 to 12 months, then is there a need for further surveillance? And lastly, what should be the duration of therapy in patients with recurrence if you have I2? The answer to the third question is probably most people would think a minimum of 2 years, but it could be even lifelong. So I come to the end of my talk, and I would like to express my gratitude once again. And as they say in Arabic, shukran ila husn and taqabbam. Thank you for the patient listening.
Thank you, Professor Puri, for this informative, elegant presentation. And please allow me to ask you a few questions on the floor. First of all, do you think that the clinical recurrence and the endoscopic recurrence carries a more progressive course rather than more than the baseline disease?
It mimics the baseline disease, but definitely patients who have very active disease and they undergo surgery, then the recurrence is much, much higher, and they would follow, if they had fistulizing disease, they would follow the same pattern of disease. So much higher risk if the initial disease was aggressive.
Okay, thank you.
Thank you, dear Professor, for this elegant presentation. And I'd like to ask you, because I'm a surgeon, your statistics concerned with recurrence rate. Okay, there are no data about the nightmare in surgery in Crohn's disease about leakage. As you said, you do iliotransverse, or create what is called the new ileum. What is the incidence of leakage after operation, and what are your options of treatment if it happens?
Well, I'm not a surgeon, so I don't think I can tell you the exact leakage rates, but in case the patient has a leakage and forms a collection or an abscess, then the standard treatment would be initially to start with antibiotics, appropriate antibiotics as per the culture, and first try and drain the abscess percutaneously with the PCD under ultrasound or CT guided, and only if that fails would a resurgery would be considered in that case. But definitely, the surgery in that situation would be very messy, because in addition to the leak, now you formed an abscess.
And would like to re-explore the patient again?
No, as I said, the
first
refashioning
of the anastomosis.
In all likelihood, you will have to dismantle and make a fresh one, because that has leaked. So yeah, although I think, as I said earlier, I'm not a surgeon, I'm a gastroenterologist, but most of my surgical colleagues feel that if that happens, you might end up dismantling that whole thing and making a fresh anastomosis.
I think it's a message for all surgeons in surgery in Crohn's disease and do anastomosis. I think proximal stoma is mandatory in surgery of Crohn's disease. You agree with me or not?
Well, a diversion ileostomy, temporary
ileostomy or proximal ileostomy.
Yes, that would always be advantageous for the patient.
Okay, thank you, dear. Thank you. Any question from the floor? Dr. Fahmy?
According to post-operative endoscopic study, how can we differentiate between ulcers of recurrence of Crohn's disease at anastomotic site and ischemic ulcers at the anastomotic site? How can we differentiate?
Well, that's a tough question. And histology won't be coming to your rescue at all, because the chances of picking up granulomas or ischemic changes, there would be a lot of overlap. You wouldn't pick up the granuloma. So you would actually be guided by the clinical situation rather than just the mere endoscopic appearance. As I said, that if you're lucky, you can demonstrate a granuloma, but the patient who's got ischemic ulcers would definitely be having other surgical complications as well. So there could be a possible leak, etc. So ischemic ulcers definitely need to be considered. But the appearance of the Crohn's disease ulcers are very typical. They are abscess ulcers, they are small, they have a hyperemic border, and in the initial stage, at least, there is a clear-cut gap between the two. And ischemic ulcers usually would tend to appear at a much later date. So even that overlap could be there. So I think one really has to go by the overall clinical situation, and histology may be of some help in a selected few only.
Okay, thank you.